Okay, this is my final portfolio for section 1. So I'm going to be comparing and contrasting an assessment that went well and one that didn't go so well. So the ones I'm going to be comparing is my third patient who had patellofemoral pain syndrome with my first patient who had facet impingement. I think the main thing that stood out between those two assessments was the confidence or lack of fear I had with the knee assessment compared to the fear I had with the spinal assessment. I sort of went in with that fear thinking, oh, there's so many joints. I had this fear of the pivums, and even with the pivums, because I had that fear, I would sort of go in stressed, and then I noticed that the more stressed I was, the worse information I got. So when I was stressed, I would dig my fingers deeper, and then I would sort of shrug my shoulders. My positioning would be off. But I did get to work on this. So with the following sessions, I was able to increase my confidence. I was able to show myself that it's not so intimidating. I know how to do it. I just have to be confident with it. I know how to piece the information together, gain from the pivums, and I know what injuries can exist in the spine, what structures are going to be involved, what special tests those structures are going to take, what that injury is going to mean for rehab. All I really have to do is I know the information. I just have to take my time to focus and not beat myself up over getting it wrong or being stressed at all. I found that just going in with fear, I started to question myself with the assessment and sort of the assessment findings. In the future, I want to make sure to occasionally practice certain assessment tests. So taking time to practice going through certain joints and taking notes on what tests I would do for certain joints and certain dysfunctions. That way I'm sort of keeping up with my skills and I know I'm not falling off. And I even stated this in activity 5. I pointed out that just going in with stress or going in with stress while I was testing sort of muddied the information that I was trying to receive, and it would sort of throw off my assessment findings. So a joint that I never assessed before like ACP was the neck. What went well was adapting to the patient's needs as many things. So I had to adapt to the patient's needs because they're in such an acute state. A lot of the things that I would have done in class, like testing supine or testing seated, weren't able to be done. So I think I was able to adapt pretty well based on what the patient could do and trying to find a way to assess without causing the patient too much discomfort. Also, as the sessions continued, I think I got more comfortable with the neck, just handling it because the neck is a fairly fragile joint. You do got to be careful with it, and I think I got more comfortable with I might have had this fear of, necks are very fragile, very sensitive. I think I got over that field just assessing it and being able to treat it and actually feeling the head and being able to gently care for it. I think I got better with the patient comfort as well. We had to go through a bunch of different positions, so I think I found the most comfortable position for the patient. What didn't go so well with that assessment was assessing the wrong joint. So the patient sort of threw me off. I knew with the history findings that the patient was reporting neural symptoms down one side, down the other, which would make sense to assess the neck. But I I guess I was stressed, nervous. I let the patient get to my head a little bit. He kept pointing at his shoulder. So I guess just to address his concerns, I ended up assessing his shoulder, but obviously everything was negative assessing the shoulder because the problem was actually coming from the neck. And it wasn't until the second session we actually treated the neck, but we were able to find the dysfunction for the most part. It was difficult dealing with this patient for at the beginning, having to adapt to the patient's acute state, just because every position we tried wasn't comfortable. The patient was constantly getting numbness and tingling going down the arm. In whatever position we tried, high seated, supine, prone. So that was difficult. All the ranges were painful, so even designing an exercise program, I was trying to think what sort of exercises he could do for the neck that weren't painful was a bit difficult. And then the patient was also very fidgety, so they were constantly moving around, and that was re-aggravating the injury. So that was another one of the struggles I had to go with. So I found over time telling the patient to try to stay still sort of helped. I guess I'm not sure why it helped, but telling the patient to stay still sort of got through to them, and they usually listened, and it sort of calmed them down throughout the session. Maybe I'm thinking it's the compassion that I was, concerned about the patient. The patient was moving around, so I asked them to, and I showed that I was caring by asking them just to calm down, and usually that ended up working and reducing the symptoms. Also, I found that the patient was in constant pain, but they couldn't understand why. So helping them understand why they were experiencing pain sort of helped put him at ease, and maybe that's why he was less fidgety and less symptoms were coming up as he was fidgeting. And I'd say with that assessment, I gained confidence with assessing next, but also being patient with all the with all the changes I had to make, and also adaptive. To prepare for the neck assessment, I reviewed my anatomy notes regarding the nerve roots because I knew he was having numbness and tingling. I wanted to find out where a nerve root impingement or disc herniation might be, or which segment. So I reviewed my notes to look at each segment and which biotomes would be affected potentially. Also, this patient was really particular about how clean the surfaces were, so I made sure to clean down all the surfaces for him. And regarding some of the feedback I received on Portfolio 5, which was take your time for the manual skills. So this was particularly important with this patient because we just had to find a comfortable position with him, and the more time I took to ensure that the patient was comfortable before we started, the more effective I found it was. A joint that I was more confident with was definitely the knee, which I got to treat throughout the semester. I think it was less nerve-wracking for me because at this point in the semester, we had already finished all of our classes on the knee. So I already had a good understanding about the anatomy, assessment, and treatment. In the past, I've also handled a lot of knees, actually picked them up, tested it. I think another thing that makes knees easier to assess for me, at least, is the easy access it has. It's sort of, you can see everything. The anatomy is all there. You can imagine where the MCL might be. You can imagine where the LCL might be, the fiber direction. So testing those is sort of easier because I can imagine stressing the fibers. The the only thing that caught me off guard with the knee assessment was patellofemoral pain syndrome. Specifically, like the tests you would use to assess patellofemoral pain syndrome. From class, I remember the critical test that we did, but I didn't really understand what a positive critical test meant. As I noted in activity 1 about help finding the cause for certain pathologies in activity 1, I asked my supervisor if there was a better test that they use that might be more indicating of certain pathologies, and they showed me the Clark sign test, and this test just made more sense to me. A positive test, I was able to understand what a positive test meant and what pathology was occurring and what structures I needed to address. So going forward, I'm definitely going to stick with tests that make sense to me and I actually enjoy, versus just doing a test because that's how I was taught to test. So comparing an assessment that I did with a model or a classmate versus a patient. In class, when we do mock assessments, usually the patient has an assigned condition and the findings are always textbook. So with a hamstring strain, for example, knee flexion is always going to be painful. But in ACP and with real patients, the findings are never that simple. They're usually more advanced, and there's other things going on. And with acute pain, everything can be painful. And there, isolating more structures with special tests becomes more important. In mock assessments, once we figure out the condition, and that's sort of it. You pass or you fail. But in real assessments with real patients, you want to know why the injury has occurred, especially if it's chronic, and it's important to assess why the injury has occurred so that you can eliminate the stressor and that the patient's not being chronically injured, or they're not going to get injured again, especially if you don't find the cause. And this is something that I noted in activity 1. I said it would be intimidating working with real pathologies because they're different from class. They're not textbook, and number 2, you also have to find the cause typically, or otherwise the injury will come back potentially. Also, when we do our mock assessments in class, typically we make up our histories, and they're not as important as histories in, sometimes we're just doing the history for the sake of doing a history and not actually listening, versus in ACP, you really have to listen so that you understand why the injury happened and how you can avoid it. So going forward, I need to continue to ask my history questions, particularly the relevant ones, and dive in where I have to. In the future, this won't be so much as an issue because you can always go back to your history questions, especially if you missed something, or if something stood out initially but you did not address, you can always go back to it. Because figuring out the important pieces is going to be important for figuring out those important pieces in the history is going to be important for assessing and rehabbing and making sure that the patient doesn't become injured again.